Good afternoon, HIV family. Welcome to our family reunion, USCA 2017, Washington, D.C. We are family. I have all my brothers and sisters with me. But I'm here to talk about champions, because all of you are champions in the fight against the HIV/AIDS epidemic. And it's always been champions like this gentleman, Dr. Robert Scott. Rest in peace. Who inspired me to reset my career and join the fight against HIV. In 1992, I was a first-year medical student at UC San Francisco, and I did a rotation at Dr. Scott's office in Oakland, where he had a small private internal medicine practice where he mainly took care of older folks with chronic illnesses. But in the late 80s and early 90s, Dr. Scott opened his practice to patients who were suffering from HIV and AIDS. And what was amazing to me at this time, these dark times of HIV, was that his waiting room would be full of little old church ladies with diabetes and hypertension. But sitting right next to them would be a young man not much older than myself, dying or suffering from HIV or AIDS. And in his waiting room, there was no distinction or separation. Everyone was there for help, and they received high-quality care with compassion and love. And Dr. Scott, his attitude was if you didn't like that situation, you could go. He was there to serve. He was not only a champion, what we call for treatment, he was also a champion for prevention. And it's funny because Dr. Scott, sometimes he would go to the local hookup spot in Oakland called Lake Merritt, where people would have anonymous sex. And he would go at night with a flashlight in the bushes. And he'd find people and hand out condoms and talk about the risk of HIV and talk about safe sex. And could you imagine a 50-year-old man surprising you in the bushes? He also started an AIDS ministry at his church in Oakland and was always an outspoken advocate for the needs of HIV patients and an advocate for HIV awareness in Oakland, which at that time still had not fully embraced the epidemic that was brewing in its community. They thought this was something going on across the bay in San Francisco and wasn't their problem. But Dr. Scott was a champion and a hero, and we still need champions and heroes like you going forward. So let's fast forward to 2017, today, and we see we've had major advances in treatment, in policy. And we have areas of the country like Kings County in Seattle, Washington, where's Seattle? Raise your hand. Right on. Where they've announced that they've reached the 90-90-90 goal for the treatment of HIV. Where 90% of patients living with HIV have been diagnosed, 90% of those who've been diagnosed are on antiretroviral treatment, and 90% of those on treatment are actually undetectable. It's a huge, huge success. And then we look at San Francisco, another city. Where's San Francisco? Right on. San Francisco has significantly reduced its rate of new infections. Even though the city of San Francisco has a high prevalence of patients living with HIV, its rate of new infections is not even in the top 20 cities for new infections in this country. And that's remarkable. We can see that San Francisco and Seattle are turning the tide on the HIV epidemic. But on the other side of the coin, we have cities like Jackson, Mississippi, New Orleans, Louisiana, where I know many folks are working diligently against the HIV epidemic, but their numbers are not approaching those of these other cities. And ironically, we can even look at Africa, a place we've traditionally associated with high rates of HIV, and countries like Botswana and Swaziland, where they're quickly approaching or have achieved the 90-90-90 goal already. We've pitied these countries for years, but will they soon begin to pity us? Maybe we have something to learn from them about how to approach the HIV/AIDS epidemic. But regardless, we have to look at the hidden epidemics that are existing in our own country. We have to look at the areas that are falling behind in terms of progress and see what are those common issues that keep the barriers in place from these areas being successful in terms of stemming the epidemic. Is it poverty, lack of education, access to care, racism, etc.? And then look at disparities and learn to understand how can we address those disparities to make a difference. So when we look at our data, we can see these disparities. As you all know, patients living with HIV and AIDS and those newly infected are still disproportionately people of color, both Black and Latino, more than 60%. We've had some successes over the past 35 years when we look at new infection rates or incidence. Overall incidence in this country has been declining over the past few years by nearly 20%. But this decline in new infections is not even. Certain groups are still struggling. When we look at gay and bisexual men, the younger age group, we see, in fact, an increase in new infections in this group over the past few years. Those 25 to 34 years old. And still, certain minority groups, Latino gay men, Latino bisexual men, young MSM, Black MSM, also struggling in terms of reducing new infection rates. And most shocking, I know all of you saw the statistics last year in terms of risk of HIV acquisition, where we still see today that among MSM, a Black MSM has a 1 in 2 risk of becoming HIV positive in their lifetime. And I'd hate to think that every time I see two of my same gender-loving African-American brothers, one of them is going to be HIV positive in their lifetime. Or you see 1 in 4 Latino MSM at risk for HIV, compared to 1 in 11 white MSM. And regardless of the number, these numbers are unacceptable. That's the work we have to do. When we look at treatment, we can see that we've had success again in terms of patients living with HIV on treatment. So we have this toolbox of testing, treatment, and prevention that has gotten us this far. But we need to keep going. We need to learn how to apply it in those areas that are failing, in those areas that have shown this level of disparity. And so the first part of that toolbox is testing. We know testing, and CDC has recommended testing routinely since 2006, actually, for all adults or all patients aged 13 to 64 at least once in their life, with more frequent testing in folks who are more at risk, such as gay or bisexual men. And testing itself allows the engagement of both HIV negative and HIV positive folks into care and into conversations around prevention and safe sex. The next piece of our toolbox, that we call it, is treatment. And we know that treatment, we've seen major advances in medications, where now medications are much less toxic and more effective than they were in the early days of the epidemic. We can now treat, even our most treatment-experienced patients can be on regimens that are simpler with fewer side effects. And we know also the DHSS has recommended that all patients who are HIV positive be on antiretroviral treatment, regardless of their CD4 count, and that a patient on treatment started early with consistent adherence can decrease the disease progression and also prevent transmitting the virus to others. And the final piece of our toolbox, which is that piece of prevention, which we've been using for, again, the past 30 years, and is a mixture of behavioral interventions, such as counseling around condom use, partner reduction, risk reduction, and structural, which is setting up programs to distribute condoms, needle exchange programs, HIV and sex education programs, et cetera. And more recently, our biomedical approaches, which is now using antiretroviral therapy, antiretroviral medications to actually impact and treat both HIV positive and HIV negative individuals. Because when we look at biomedical interventions, we can see that using them, we actually can use them to treat patients who are positive for HIV by reducing their viral load to undetectable levels and preventing transmission, and treating HIV negative individuals to prevent acquisition of HIV, both through the use of PrEP and PEP. But it's important to understand that these medications aren't useful by themselves. They have to be integrated into a matrix of care. In HIV-negative folks, medications have to be used with a comprehensive prevention strategy, using those behavioral and structural efforts we talked about. And for HIV-positive individuals who are being treated for HIV, to get to the undetectable levels, they have to remain adherent. So we need to continue to support them and address their competing priorities, such as housing, food, mental illness, substance abuse, etc. And it's important, of course, that always there's open communication between providers and patients about these issues, those on treatment and those who are receiving preventative therapies. So we have this toolbox of interventions that have taken us this far. And as we know, the numbers are better in lots of areas, but we need to take this toolbox even further. We have to retool this toolbox to now address the areas that we're lacking, those gaps that we have. That's where the reset comes in. Right now, we're in times of extreme uncertainty about the support for healthcare in this country, especially for HIV care and services. So I call on you, all of you who work in HIV, to understand we have to double down the work we're doing to support our patients. We have to address the issues of societal stigma, complacency, and lack of empathy for our patients whose battle many times is not with the HIV virus, but it's with the unsupportive world that they live in. We have to reset our focus. We have to reset again and retool our energy and reset our focus on disparities. We have to look at the HIV treatment cascade, look at the disparities we see, and address each of them: testing, linkage, retention, and adherence to treatment. We need to look at cities like Seattle and San Francisco and see the possibility of what they've achieved when we use the right policies and the right tools and the right collaborations between organizations. And we have to address issues that are greater than this room. And I have to say it: poverty, lack of education, homophobia, transphobia, racism, and even the racism within the gay community. We have to reset our commitment to ending HIV stigma. And that could start with advocating for routine testing in all healthcare settings so that getting an HIV test is just as normal as getting a test for cholesterol or blood glucose. We have to educate all our healthcare and community providers that HIV treatment, testing, and prevention are a normal part of healthcare. And we have to do one other thing. We have to ensure that the barriers and missed opportunities for health that exist for patients living with HIV and those at risk for HIV are taken down. And finally, we need to reset our inspiration. You need to recognize the champion in each one of you in this fight against HIV. The fact you're here today shows that you have this ability. Because remember, from the start, it was champions like Dr. Robert Scott, rest in peace, who allowed us to reimagine how we can approach HIV care. And it will be you, the champions in this room, with your continued work, effort, and now inspiration, and now our reset, will ultimately bring an end to the HIV epidemic. So thank you for being champions, and God bless you.